Uh, Hello, welcome all ICI members. So this month academic meeting is about pre and post TAVR imaging. Dr. Ritu Agrawal and Dr. Prashant Dwivedi from Eternal Hospital, Jaipur will take it ahead on this important topic. So this is a TAVR imaging, as you know, that for aortic stenosis, it is becoming very useful modality for patient. So it is important that we know about pre as well as post intervention imaging. Over to you, Dr. Ritu.
Thank you, Dr. Priya. Can I start my screen sharing now?
Yes. Amit?
Yes, ma'am, she can start it.
I don't know why I cannot see that pop up. Okay, let me try once more. Yeah, okay. So can you guys see my screen?
Yes.
And am I audible enough?
Yes.
Okay. Thank you, team ISAI, for having me today here. So today I'm going to, as Dr. Priya said, I'm going to talk about pre and post TAVR imaging. And the idea is to know as when we do TAVR, what we should know before doing TAVR, how do we reconstruct these images, and how TAVR can also be used as a post-operative tool. So basically, what is aortic stenosis? So aortic stenosis is when we have a jet velocity of more than 4 meters per second. The mean gradient is more than 40 to 50 millimeter mercury. And the aortic valve area is less than 1 centimeter square. And when the valve area is less than 0.6, then it is critical aortic stenosis. Now, aortic stenosis is a significant cause of morbidity and mortality. And the two major causes of aortic stenosis are calcific aortic valve disease and rheumatic disease. So, as the name says, in calcific aortic valve disease, there is significant valve calcification, thickening, commissural fusion. This is a contrast CT image, an axial image, which is showing nearly tricuspid aortic valve with significant calcium. Now we can do a non-contrast CT and then calculate the calcium score on this non-contrast CT as well. And when we have some very interesting data over multiple articles, which is showing that if the calcium score is more than 2000, then we are dealing with a case of severe aortic stenosis. Now, this is important because when just by doing a simple calcium score, we can quantify the degree of stenosis in case of these patients. And the actual cutoff numbers are 1377 for females and 2062 for males. So roundabout, if we have in any lady a calcium score of more than 1200 and a male of more than 2000, then we know we are dealing with a patient of severe calcific aortic stenosis. Also, the pattern of calcification also sometimes tells us about the valvular morphology. Now, that is another case. I just wanted to show how a rheumatic heart disease looks like. So we know we can see a tricuspid aortic valve. We have some degree of focal calcification of the valve, and this is a systolic image. We can see it is RR 20%, where the aortic valve is completely open. And that is a diastolic image when we have this RR interval 70%, but we can see there is small central area of non-coaptation even on the diastolic phase images, which is telling us that the patient has AR as well. So the valve is thickened and calcified, telling us it is aortic stenosis. And we have these non-coaptation areas on diastolic phase images, which is telling us that that is AR along with AS. Now, that is the same patient with the mitral valve. And we can see there is extreme thickening of the mitral valve with some degree of calcification. And there is a mitral stenosis, that is the diastolic phase with the thickened calcified mitral valve open. So this is a case of rheumatic heart disease because there is multiple valvular involvement, and the involvement of mitral valve is more severe, more common as compared to the aortic valve in case of rheumatic heart disease. Of course, tricuspid and pulmonary valves can also be involved. So these are the two major causes of aortic stenosis, calcific and mitral valvular disorder. And in this case, in this cases, radiation heart disease is also a differential. However, in radiation heart disease, the aortic valve is more often involved as compared to the mitral valves. So basically, TAVR imaging is transaortic valvular replacement, and this is transcatheter valvular replacement, aortic valve replacement, and this is done for patients who are not candidates of SAVR, which is a surgical replacement of the valves. And why they are not surgical candidates? Because of these multiple comorbidities, which includes the patient may be frail and of old age. He may have a prior radiation therapy with significant damage to the chest, or a heavily calcified aorta, or severe pulmonary hepatic disease, chest deformities, and also in case of depressed renal function, previous stroke, PVD, and reduced LV function. So in all these patients, we are not fit for surgical candidates. In those patients, we consider TAVR imaging. Now, the goal of TAVR is to replace the native aortic valve and replace it with the prosthetic valve in the aortic annulus. And the native valve is actually not dissected or not removed. The leaflets are crushed to the periphery. As I'll show you in the subsequent images, how does it looks like. For now, I would like to introduce these two TAVR devices that we have and most commonly used. One is the Edwards Sapiens and another is the CoreValve. So the Edwards Sapiens is essentially a short craniocaudal height, and it just sits in the aortic annulus and extending up to the aortic sinuses. It does not extend beyond the sinuses into the aorta, unlike its counterpart, which is the CoreValve. And these comes in multiple sizes of these 20, 23, 26, and 29. And I'm sure Dr. Prashant would take us how do we select these sizes. And the advantage of these is that because it has a short length, it can be deployed in the aortic annulus without any significant limitations in terms of the size of the sinus of Valsalva or the sinotubular junction, or without any hindrance from the diameter of the ascending aorta. That is another device which is available for TAVR, which is a core valve or the revalve system. Now this portion of it sits in the aortic sinus and the aortic annulus, whereas the top portion extends into the ascending aorta. And these comes in different sizes of 23, 26, 29, and 31. Now, the advantage over the previous valve that we saw is that the sizes are much more wider, and therefore they can be used for patients who have larger annular diameters. Now, this is a self-expandable frame. That means soon as the valve is in place, it opens up on its own. And but the disadvantage of this is because this extends into the aorta, and it is closely abutting the LVOT where we have the AV node. And therefore, this valve actually sometimes damages the conduction system, and therefore may need a permanent pacemaker. So this is when we have any problem with the aorta, we would prefer this valve. And when we have a larger annular diameter, we would prefer this one. But the drawbacks are having a possible conduction issue. Now that, so technically TAVR can be used when we have aortic annular diameter between 18 and 29 mm, combining all the devices, both the devices that are available and all the models that we have for them. Now, what is the role of imaging? So the role of imaging is to provide the cardiologist with a framework on how he would select the valve, which type of valve he would like to use, he or she would like to use, and then guide the assessed site that they would like to go from the femoral approach or the subclavian or the aortic or the LV apical approach, which is less common, but maybe some centers still use them. So we have a retrospective gated. So mind it, this is not a prospective study. This is a retrospective study and high resolution scan of the aortic root and the heart. And then this is followed by a second non-gated images of the aorta. which is minimum at least 3 millimeter or lesser in thickness and extending up to the mid thigh. So we cover the bifurcation of the common femoral arteries extending up to the superficial and deep femoral up to the mid thighs. Now, why do we have, and we give only one single bolus of contrast. Initially, we were using up to 80 to 100 ml of contrast, but now we have a newer machine, Philips 256 scanner, and therefore we are trying to do it with lesser amount of contrast. And we have been pretty successful so far. So now, why do we do a retrospective gated study? So retrospective means that we are acquiring through all phases, that is including the systole and the diastole, and not just doing the diastolic imaging as we do for coronary arteries. So this actually increases the radiation dose. But then since the patient are usually older, we are not very worried. What is important is the patients tend to have irregular heart rate, and we need to see all the phases because each one of them contribute differently to TAVR planning, and therefore we need all the phases, and we would do a retrospective imaging. And this non-gated images of the aorta helps us to plan the assess, which I'm going to show you how to do it in the next few slides. Now, if the patient has contraindication to contrast, if the patient is in renal failure or have some allergic tendencies or some other problems, then what we can do? So what we do then is we do non-contrast images of the aorta. And okay, somebody is saying the volume is low.
No, it is perfect. I think I'll just tell her it is from her side. The volume is perfect.
Okay, thank you then. I'm actually not looking at the chat as of now. I'll finish my talk and then I'll look at the chat and the QA, whatever we have. So in patients who have contraindication to contrast, then we would take a non-contrast images of the aorta for establishing the vascular assess, and then we can do a CMR. A CMR similar to a CT for the aortic annulus, valve, root, and the coronary ostia. So for this, we do a ECG gated, non-contrast SSFP cine sequence, similar to what we do for assessing the ventricular volumes. We take to 6 to 8 millimeter slice with no gap, zero gap, and we take the slice from the aortic valve and to the aortic root. How does this look like? I'll show you in the next slide. So we do not give routine beta blockers because the patient already has a severe aortic stenosis and it might be problematic for them. And then we have a high incidence of arrhythmias in TAVR candidates, and therefore we do not use prospective gating. We use a retrospective gating, as I said previously. The radiation is acceptable because the patient is old and we do not want to miss out any information. And then TAVR is a costly procedure, so we want it to be successful, not just trying to save some radiation here. Now, the primary goal of these images of the aortic root and the heart is to size the valve, is to tell the cardiologist which size valve to use and which of these to use among the two, depending on the patient anatomy. And then it also gives us information on the coronary arteries, the morphology of the leaflet, the calcification of the leaflet, and any other challenging anatomical features. So why we have to be very clear about the coronary anatomy. So what happens here, I'll just skip a few slides and come back here. So that is a sapien valve, that is a sapien valve in position. So what happens here, that is a TAVR valve when we have a metallic strut, and on these are bioprosthetic valve. That entire thing is a TAVR valve. So where is a native valve here? So this native valve is kind of pushed here to the periphery and the TAVR valve takes in place. So now if the height of the coronary ostia from the annulus is less, or if this leaflet is very long, then this leaflet can actually, that is a bioprosthetic leaflet, that is a native leaflet is very long, then this leaflet can actually block the coronary artery ostia. And that can become a real big problem. And therefore, we have to be very specific about the coronary artery anatomy. So now there is no definite exclusion criteria, but most cardiologists that I've worked with have a minimum 10 mm cutoff. So that ranges from 11 to 14 mm, but they would not do it for less than 10 mm. So if the cornea ostia are less than 10 mm in height from the annulus, then a TAVR procedure is not usually done. And then any other anomalies of the coronaries, like we may have a anomalous coronary artery origin or significant coronary artery stenosis, they can also affect the procedure. Now we also need to look at the sinus of Valsalva, the width and the maximum height. So why do we want to know about this? Because we want to see if the TAVR valve will be able to sit properly within the sinus of Valsalva without causing any coronary occlusion from the displacement of the native valve, as I've shown you previously. And it is especially important when we have a core valve device, because we need a minimum 27 mm of sinus of Valsalva diameter if we want to have a 26 mm prosthesis, and a minimum 29 mm diameter for 29 and 31 size prosthesis. And the height should be minimum 50. So we have to clearly document the transverse diameter, the maximum transverse diameter of the sinus of Valsalva from sinus to sinus in a true axial plane, and the height of the sinus of Valsalva. Now, the diameter of the ascending aorta is also very important. If the aorta is more than 43 in size, and this 43 is measured 4 centimeter above the aortic annulus. So you go from the aortic annulus 4 centimeter above it and you measure the aorta at that plane. If the size is more than 43, then we cannot use a 29 and 31 mm core valve device, because as you might remember, as I said, the core valve device will sit partially into the ascending aorta. And if the diameter of the aorta is more than 40, then we cannot use a 23 and a 26 mm device. So for a radiologist, you must clearly measure the aortic sinus, the sinotubular junction, the mid-ascending aorta, the distal ascending aorta in a very true axial plane. And the size is actually of the aorta is less concern for the sapien valve, because they are short in length, and they sit just in the annulus and the Valsalva and the sinus of Valsalva. They do not extend into the aorta. So the size is matters a little less on those valves. Now, why annular sizing with CT is important? Conventionally, annular sizing has been done by using echocardiography, both transthoracic and NTE. But as we see on CT, that is a systolic phase at 20% error, and that is 60% error. We can see the size of the annulus actually changes, and it goes change in shape as well over the cardiac cycle. So the annulus is not a simple circular structure, it's mostly elliptical and oval, elliptical or oval in shape, and it goes changes in shape over the cardiac cycle. So that is why we scan through all phases of this cardiac cycle, and we take where the annular diameters are maximum. You can see the diameters are maximum in systole, which is 20%, has the maximum annular diameter. And usually, we take diameters between 30-40% of the RR cycle. Some cardiologists also prefer to have a 25% RR interval diameter. So this we have to work with the local team. How do they want it? And why do we measure the largest diameter? Because we do not want to undersize the prosthesis. So what would happen if we have a smaller size prosthesis? It will slip away during the cardiac cycle. And so we do a small degree of oversizing. But then we should also not do a large oversizing, because then that might cause a rupture of the annulus. So usually we measure diameter 25% and 35%. That is what I give in my reports. And sometimes even 30% diameters of the annulus. Now, how do we do it? So this is what you get, image of the aortic root. Now you bring your cursor here on the aortic valve, and then you align it. So once you bring it here, that is a sag, that is the axial, that is a coronal image. That is just the beginning. I have not done anything with the mouse. I've just brought my cursor here and positioned it here. Now, once I'm here, I try to align it in such a way that I get a true cross-sectional image or an en face image So how do I get that? I align this blue line to the center of the ascending aorta. You can see it is perfectly perpendicular to this annular plane. Then I go and align this yellow line on the coronal image. I turn it like this so that this line becomes again perfectly perpendicular to the annular plane. And when I do these two steps, then I get this, which is the end facing view of the aortic valve. Now, once I'm here, I can see the 3 coronary cusps, and that is the aortic sinus. Now I scroll a little bit down and I go here and I get the annular plane. So once I scroll a little bit down on this image, I get this annulus. And once I have this picture, then I take the long axis and the short axis diameter of the annulus. I measure the area of the annulus. Then I use another tool to measure the circumference of the annulus. I go slightly up at the level of the aortic valve and calculate the valve area. Then I measure the distance of the coronary ostia. This is the left, and similarly we'll have the right on another image, and we measure the distance from the annular plane, and then I measure the leaflet length. And all these information is documented in the TAVR report. Now, sometimes these 4D images, besides all the information, the 6 points that I mentioned in the previous slide, we also get other useful information. For example, we see the LV hypertrophy. Now, this LV hypertrophy is important because if there is a significant septal bulge into the LVOT, then it can be challenged to the operator for proper positioning of the valve. And then AV node is also located somewhere close by, and then we may have a possible injury to the conduction system. Now, if we have a left ventricular dysfunction, which we can see, some of the cardiac scanners also have the software to calculate EF, and sometimes you can see visibly as well as. So then if there is some degree of left ventricular dysfunction, then it can also affect the strategy for performing TAVR. Now, if you have a pre-existing aortic regurgitation, which is seen as a non-coaptation area, then balloon dilatation, which is usually done prior to placement of the valve, may worsen the severity of the aortic stenosis. And if you have a left ventricular thrombus in a case like this, then it also changes the strategy. So this was one of our patients. I don't know, for some weird reason, this thrombus was not seen on echo. It was something to do with the density, the echogenicity of this thrombus. And then we did a TAVR, we found this thrombus, and then the cardiologist successfully implanted a TAVR valve using bilateral carotid filters to prevent any microemboli to the brain. So this is how a TAVR imaging, like this images of the heart that we get, not only gives us information for sizing of the valve, but allows us to give a lot of other additional information. Now, sometimes besides these, I don't have a picture as of it, but sometimes you have to also, every time you have to look at the lungs and along other structures also carefully. Sometimes you have these masses in the lung. Now, if a patient has a shortened lifespan because of the CA lung, then putting a valve in that patient is actually a difficult choice or is not justified. And then that changes the way we look at the patient. So we have to look at the patient as a whole and not just look at the heart, because ultimately we are treating the patient and not the valve. Now we have this non-gated images, so we have to look for the assess. So we have a transfemoral assess, a subclavian, and a transaortic approach. So for vascular assess, traditionally it has been thought that the minimal luminal diameter should be at least 7 to 8 mm. However, now there are new delivery system, and people are doing it with lesser diameters, and I'm sure Dr. Prashant will be able to tell us more on this. Then we have to also document any unfavorable anatomy. So what is that? If there is a calcified or a non-calcified plaque which is protruding into the lumen and making the lumen smaller, then the cardiologist should know beforehand that he should be careful navigating through that area. If there is a focal dissection flap, then again they have to be careful because it can turn into a full-blown dissection. Then if the vessels are very tortuous or kinked, then again that has to be documented, because then it changes the type of guide wire they are using for performing the procedure. And if they have these kind of thrombi, then there's an increased risk of cerebral embolization, and then they have to use those carotid filters. Now, if we have a lot of atherosclerotic disease in the iliofemoral system, then if there is a circumferential calcification or calcification at the bifurcation, then it is a contraindication to transfemoral approach, because then the puncture becomes difficult. Once the puncture is done, then calcification doesn't matter a lot. Now, when they're planning a transaortic approach, similarly, a calcification in the ascending aorta is a problem. And even if they have a non-calcified plaque, then they also have to be careful, because if it gets dislodged, then the patient might develop an embolic stroke. So all these things have to be documented beforehand in the report, and so that the operator is aware of what possible problems might arise, and is adequately prepared for them. So this is when there is a soft plaque in the left common femoral artery. And then again, I place my cursor parallel to the long axis and then align it again on a coronal image to get a true axial image. And now the minimal luminal diameter is measured in this. It is not from wall to wall. It is the diameter of the lumen, because the sheath is going to go in the lumen. So the diameter is here 0.8 rather than 10 or 11 mm if I would have measured the entire vessel in a transverse wall-to-wall fashion. So that is what you mean by minimal luminal diameter. You have to actually measure the diameter only of the lumen, excluding the wall, the thrombus, the calcium, whatever is. Now, this is what I was talking about, CMR used for quantification of aortic stenosis when we have this patient with renal failure. So what we have is a cine image. Now that is a left atrium, left ventricle, and the aorta. We see a significant thickening of the aortic valve with flow acceleration, which is seen as dephasing jet, telling us that the patient has aortic stenosis. Now these are the actual images through the same patient. So we are going down. I'm sorry, we are coming up, like going from year to year. So I'll run these images once more. So here, that is somewhere below the annulus. This is the annulus. This entire thing is the annulus. Now, as we go more cranially, that is the aortic valve. You can see the tricuspid aortic valve. And that is where I would do my planimetry, would measure the valve area. And then I go up, that is the sinotubular junction. Going further up, I've come into the aorta. So when we have a problem with CT, we can use MR. So MR, we can measure the annular diameter similar to we did on CT, and we can also measure the aortic valve orifice area similar to we did on CT. Although MR is more technically difficult to obtain and is used very less as compared to CT. It is only when the patient has severe renal failure and contrast cannot be used. We cannot use even a low dose contrast. So this is a post-TAVR imaging of how a sapien valve looks like. You can see that is a metal strut, and these are the biprosthetic leaflets. The valve is placed into the annulus and the aortic sinus. The native valve is displaced on the periphery, and the valve is clearly equally opposed. There is nothing of a nodular calcium or something sitting outside, preventing the complete opening of the valve. So it should be completely open, unfolded at all levels. And that is a core valve. So you can see that part of it starts from the annulus, goes into the sinus, aortic sinus, and extending partly into the aorta. This calcium here is a native valve, which is displaced peripherally because of the TAVR valve. And this is how it looks like at the inflow at the level of sinus and into the aorta. Now, we have sometimes failed valves. So valve-in-valve TAVR is when the patient already had a TAVR done. For some reason, it failed, and then we have to put in another TAVR. So when they do a valve-in-valve TAVR, they put the new device inside of this previous valve ring. And now this biprosthetic leaflet of the TAVR valve is kind of crushed away, and another valve come and sit in its place. So when we have a valve and valve TAVR, we have to actually measure the diameter of the internal ring, the TAVR ring, because that decides about what new valve, what is the size of the new valve they can take. Now, when some people have also used echo for sizing, but actually when the patient has a metal prosthesis, echo has a lot of artifacts and therefore CT should be done for sizing. Now I'll come to role of CT in post-TAVR complications. So the most important is paravalvular regurgitation. Now, what is the cause? The most important, there are three main causes. One is the size mismatch when we have a smaller device as compared to the size of the annulus. So it doesn't fit in properly and there is space and there is leak. So paravalvular, as the name says, there is regurgitation. There is leak along the side of the valve. And then the other problem is the aortic valve calcification. And the third problem is the incorrect positioning. So the calcification, if we see on a pre-TAVR CT, this is a kind of bulky calcium if we are having symmetric or asymmetric, or we are having a calcium of the outflow tract. Then it is a risk factor for developing PVR. So there have been studies which are showing that if the Augustin score is more than 3000, and if we have a mass-like calcification of greater than 800 milligram per millimeter square on a contrast CT, then the risk of PVR is high. Now, this is how a nodular calcium, a significant calcification of the valve would stop the complete opening of the TAVR valve. So you can see this valve here is not completely open. It should be having a round circular shape as I showed you in the previous study, but because of these nodular calcium, there is incomplete opening of the valve, and therefore this space is left and there is leak of blood extending across this valve, giving rise to paravalvular regurgitation. That was another case, aortic root rupture happened post-TAVR. We can see that is a TAVR valve, the bioprosthetic leaflets, it's well placed in the aortic sinus, but then there is rupture of this aortic root non-coronary sinus in the right coronary sinus. And there's also was an abscess pocket on the left main coronary artery, which was not seen on CT, which was seen on post-op during the surgery. So these complications can also be well seen on post-TAVR studies. Now, besides that, what is one of the most important complications is hold. So hold is hyperattenuating leaflet thickening. So what happens is when the patient comes for TAVR and they have a follow-up studies, follow-up echocardiography on a month, there is increased gradient, and there is aortic insufficiency, which makes the cardiologist worry if the valve is failing. So now what they do, we do a CT in these patients, like in this case, if we see the valve is well seated and it's moving well, there is no significant thickening of the prosthetic leaflets. So there is no low density areas which suggest thrombus formation. So this patient is not hold. Then what does hold look like? So this is what is hold. So we have again a TAVR valve, but we have these nodular thickening of one of these cusps. You can see it on a coronal, on a sagittal, on an axial image. So this is the hold, hypoattenuating leaflet thickening of the non-coronary cusp. And once you have diagnosed hold, then you can also use TAVR, a similar TAVR protocol to see if the hold is resolved on follow-up imaging. So this was a patient who was showing this hypoattenuating thickening. And this patient, when we did a 3-month follow-up CT, we can see this thickening has completely gone. Now, there are studies who have graded this hold into 4 categories, depending on how far this thickness extend, like 1, 2, 3, and 4. However, these are fairly subjective, and I'm not sure that changes the management. If the patient has hold, then of whatever grade, it means the patient needs to be more closely followed up for any potentially valve failure. One more complication. So this again is a TAVR patient. You can see the valve is well seated here. But as we go up into the ascending aorta, we can see this hypoenhancing areas along the anterior aortic wall. And this is actually an intramural hematoma. And intramural hematoma is now a type of class 2 dissection. So this patient was managed along the lines of dissection. And we can see, so what we have seen is that TAVR imaging helps in pre-TAVR workup for selecting the valve, guiding the cardiologist for proper assess site, and therefore radiologist is an essential part of the TAVR team. And it also helps in managing the post-op complications. So one more, this is a valve-in-valve TAVR. And we can see this is the bioprosthetic ring, and the valve leaflets here are extensively calcified and thickened. So the patient has a re-aortic stenosis of the bioprosthetic valve. And when we look at the 4-chamber image, we can see there is actually a low LV function. Even on visual eyeballing, we can see that. And we also see there is some ballooning of the LV apex. So we know that the LV aneurysm is there. There is poor function. The valve is not functioning. So this is one perfect example of how we should not only look at the valve, but the entire heart. As I was saying, that images taken for the root helps us to assess the LV function as well. So that is all I have, and I will take up if there is any questions. So Dr. Priya, how should we go? I mean, should I, if anybody has any questions, should I take them, or should I wait for Dr. Prashant to finish his part? I think so. Dr. Prashant can take from here. And at the end of the session, we can come and take if there is any questions.
Thank you, Dr. Ritu. That was an excellent presentation of how to analyze the CT as a pre-TAVR and the post-TAVR both. So in next few minutes, I'm going to start my presentation. Can I share the screen, please? Is my screen visible?
Yes, we can. We cannot see your presentation, but we can see your screen. Yes, we can see your presentation now as well.
So in next few minutes, I'm going to cover all these topics. So how to do the step-by-step three-dimensional analysis, how to select the valve size, when to protect the coronaries, importance of calcium distribution, and how to select the vascular access. And I'm also going to talk about what are the hostile anatomical CT feature for the TAVR perspective. So as Dr. Ritu has already mentioned about the different valves available, there are certain balloon expandable valves, certain self-expandable valves, and there are certain other designs also. So the balloon expandable valves are basically the annular valve. So where the valve leaflets are basically at the level of annulus, while the self-expandable valves are mostly at the supraannular valve, where the valve leaflets are relatively above the native annulus. So there are many valves are available now, even in India also. So there are certain Indian made valves are also available, certain US FDA valves are also available. And so now begin with the step-by-step three-dimensional analysis. So we all know that for the transcatheter heart procedure, planning is the key. So if we have a good planning, we can execute well. So planning, so in during the TAVR procedure, all is 90% is planning and only 10% is execution. So so why do we need a planning? So planning is basically to understand the anatomy of the different patient and to understand the how device, and then we need to understand how that device is going to work in that anatomy. So that's why this planning is very, very important from the any interventional perspective. So for the tower perspective, CT is the key for the pre-procedure planning, because if we know what exactly we are going to find and what size of the wall, what exactly we have to do, we can execute very well. So why do we need a proper imaging? So we need to understand whether the transcatheter intervention is feasible or not. We need to understand what will be the best suitable access for the procedure, what type of wall need to be implant, and what size of the wall should be implant. We need to identify the high risk hostile anatomical features. We need to anticipate any complication, and we need to decide any bailout strategy. And we also need to assess if there any feasibility and need of any other complementary strategy, what we usually routinely do for the during tower procedures. So I'm not going into detail about the CT scan requirement. So these are the steps for the tower CT analysis. So what are the steps? First, we need to understand whether the valve is bicuspid or tricuspid, as Dr. Ritu has already mentioned about this. Then we need to understand the annulus, and then we need to define the measurement of annulus, because this is the most important part during any tower procedure, because this is the part which will gives us an idea what size of the wall we are going to implant, and all the measurement is going to be affected from this annulus measurement. If we don't take a proper annulus measurement, then all the measurement will be affected uh, from during the CT analysis. Then we need to understand the LVOT measurement, sinus of Valsalva, STJ, coronary height, coplanar angle, aortic root angle, calcium distribution, membranous septum length, and the femoral overview. I will go in detail about each and every. So first of all, we need to understand the aortic root measurement. So during aortic root measurement, we need to understand what is annulus, what is LVOT, what is sinus of Valsalva, and what is STJ. So we can see this green line. This is basically an annulus. This yellow line is basically sinus of Valsalva. This is STJ, the red line, and the blue line is basically a LVOT. So why we need these measurement need to be taken? So in actual anatomical fact, so annulus is basically not a true anatomical landmark. This is a landmark which we derived through the CT scan analysis, because there is no true exactly annulus. All the three cusp of the aortic wall are not at the same level. So there might be every patient has a different anatomy. So there might be a possibility that non-coronary cusp might be slightly higher, left coronary cusp might be slightly lower. So these all three cusp are not in a same line always. So that's why we need to define the nadir of all the three cusp, and by combining the nadir of all the three cusps, we can make a proper annulus. But this is not a true anatomical landmark. This is a CT derived landmark. So how do we do it? We can see this ring. So this is basically a non-coronary cusp, this is a left coronary cusp, and this is a right coronary cusp. And if we look at the nadir of all the three cusps, left, right, and non-coronary cusp, where all the three cusps are being combined, and then we are making a green color circle. So this circle is basically a annulus, but this is a virtual ring which we derived through the CT scan. And by this virtual ring, we will decide which wall we are going to decide. So this is the same thing. We have to decide the nadir of all the three cusps. So this is how we are deciding all the three cusp nadir, and then we have to make a circle, and that will be our annulus plane. So how to select? So what we need to do is we have to decide the annulus during the we have to do it in the systole, because the reason is in the RR 30 to 40% of cardiac cycle, we will get a maximum size of the aortic annulus. So that's why we want to take the aortic annulus which is maximum, because if we undersize, there will be a chances the patient may develop wall embolization at the time of procedure. If it's oversized, there might be aortic root injury, rupture, bundle branch block, or complete heart block. If it's undersized, there might be device embolization or the paravalvular leak. So that's why the valvular sizing should be perfect. So how to decide the annulus plane? So what we need to do is, first we need to go in the systolic phase. Then we need to adjust the central line across the section. So what we are going to do is, so first we in the three-dimensional analysis or in the any CT analysis, what we do is we all the three phases in the cross-sectional, longitudinal, and coplanar, and in the orthogonal views, all the three orthogonal views, whether it's a sagittal, cross-sectional, or oblique view, we need to make the central line should be there in all the views. So you can see we are adjusting the central line in all the three views. in the cross-sectional, longitudinal, and the sagittal plane. Then what we are going to do is we will bisect the annular plane. So what we are doing is we are bisecting the annular plane, and because at this level we are getting the maximum width of the sinuses, and after bisecting we are going down, slowly scrolling down, and then we will go to the nadir of the each sinuses. So first we will select the nadir of left coronary sinus, then we will select the nadir of the right, then non-coronary, and we give a point for the each sinuses. So this red point is for the left coronary sinus, this green is for the right coronary sinus, and this yellow is for the non-coronary sinus. And after getting these 3 points, so basically these 3 are the nadir of all the 3 cusps, left, right, and non-coronary cusp. And then we are going to combine all these 3 cusps. So this is how we have combined all these 3 cusps, and this will give us some dimension. It will give us a dimension of minimum dimension, and will give us a dimension of maximum dimension. It will give us a perimeter derived diameter, area, and area derived diameter. The importance of these measurement is very important. The minimum dimension is basically important because we cannot do a BAV, balloon dilatation, beyond the minimum dimension, because if the annulus is oval, we cannot do a BAV which is with the size of a wall, with the size of the balloon which is more than the minimum dimension. So if my suppose a minimum dimension is around 18.2, I will not go with a 20 millimeter balloon dilatation. I will just go with the 18 millimeter balloon dilatation. So that's why these are the important. So then we need to assess the LVOT. So LVOT, we usually assess the LVOT from the annulus to up to 1 to 5 millimeter. We have to see how the LVOT is going to behave in respect to the annulus, whether the LVOT is relatively larger or the smaller than the annulus. Because if the LVOT is larger, the wall during the deployment is going to dive into the LV. If the LVOT is smaller, or if there is an septal bulge, the LVOT may push the wall up, so it may embolize or it may pop out. So that's why we need to understand whether the LVOT is with the same size of the annulus, or is it smaller or the larger. We also need to understand if there is any annular or LVOT calcium, because if there is any LVOT calcium, there might be a risk of PBL, rupture, pacemaker requirement. So that's why the LVOT is very, very important. Then we need to understand the sinus of Valsalva. So what is sinus of Valsalva? It is the widest portion of the sinuses. We need to measure the length from the leaflet to the opposite commissure, and and we also need to measure the height of the sinuses. So we can measure the sinuses height where the sinuses are going to be maximum size. So it is the sinus of Valsalva is basically important to assess the valve size, risk of coronary obstruction, and risk of sinus sequestration. So then we need to understand the sinotubular junction. So where exactly is the sinotubular junction? It's a junction where the sinus of Valsalva is meeting with the ascending aorta. So it is a portion where the vessels start circular again. So we have to measure the smallest diameter and the largest diameter. And we also need to account the calcium, because if there is a calcium, there is a high risk that STJ might rupture during the wall deployment, especially with the balloon expandable wall. Then we also need to assess whether the STJ is smaller or larger, because if the STJ is smaller compared to the annulus, then there are chances that the wall may go deep towards the LV, because the STJ size is small, so it might push the wall towards the left ventricle. So that's why we need to understand what is the size of the sinus of Valsalva, STJ, and then we also need to understand the ascending aorta. We have to measure the diameter. If the ascending aorta is too much dilated, if suppose diameter is more than 45, then we might need to consider for the Bentall procedure or surgical aortic root replacement along with the surgical aortic valve replacement, rather than putting the patient on the tower wall. Then we also need to check the presence of any aneurysm, tortuosity, and calcification, because these things are important during the negotiation of the wall and to make the trajectory smooth. So that's why we need to understand whether we are going to face any difficulty while going with a wall inside the annulus. So if there is any difficulty, so we might need to change the strategy with a more stiff wire where we can easily negotiate the wall. So then few points about the bicuspid aortic wall. So the bicuspid aortic wall, we all know about the bicuspid aortic wall. There are different types of bicuspid aortic wall: type 0, type 1A, type 1B, then type 2. But from the intervention point of view, rather than the type, we are more concerned about whether it's a bicommissural valve, or whether it's a tricommissural. Second thing, whether there is raphe is present or not. Third thing, whether the raphe is calcified or not. So you can see this is a type 0 bicuspid with a bicommissural and non-raphe. This is a bicommissural with a raphe which is fused between the left and right fuse raphe, but this is not calcified. This is a type 1b bicommissural right and non-calcified raphe. This calcified raphe is one of the hostile anatomical feature which may keep the patient at risk during the procedure. Then this is a tricuspid or a mixed cusp fusion valve. So why we need to understand the bicuspid aortic valve, because this has a peculiar anatomical feature, and there is still a lack of consensus on optimal sizing in the bicuspid aortic valve, because the bicuspid aortic valve has a larger aortic wall component, larger sinuses, higher calcium burden, presence of heavily calcified raphe, and associated aortopathy. And because of these complex bicuspid anatomy, there is high chances of complication during the procedure, especially the risk of pacemaker, risk of brain injury, because the calcium burden is high. So there might be chances that the calcium may go up and into the brain and can lead to a stroke. Then there are chances of aortic dissection, because bicuspid aortic valve are many times are associated with aortopathy. And there are chances of risk of annular rupture because of the severe calcification. So then there are different sizing method of bicuspid aortic valve. We can go with annular sizing, we can go with the supraannular sizing, and there are certain other sizing methods also. So why we are talking about the supraannular sizing? Because the bicuspid anatomy is not like a tricuspid anatomy. There is some difference are there in the bicuspid and tricuspid anatomy. We need to understand whether the valve and the sinus of Valsalva are behaving like a tubular form, whether they are behaving like a flare, or whether they are tapered. So because in the bicuspid aortic valve, we don't want any much oversizing. So whatever is the minimum, we need to take that in account. So if the annulus measurement is and the annulus and the supraannular measurement are same, then we can take the annular measurement. If the annulus measurement is low and the supraannular at the 4 millimeter above the distance is high, then we still take the annulus measurement. If the annulus measurement is high and the supraannular measurement is low, then we will take a lower measurement, that is supraannular measurement. So overall, in most of the time, in 88% of the time, we can still go with the annular sizing for the bicuspid aortic valve. Only in 10 to 12% of the patient will require a supraannular sizing. But we need to understand whether the valve is going to behave like a tube, flare, or taper. So then annular sizing is similar to bicuspid aortic valve. So just an example of how to decide the supraannular sizing. So this is an example where this is the annulus dimension. So here you can see this. So what we need to do is we need to identify the annulus. Then at the 4 millimeter above the annulus, we need to measure the intercommissural distance. So this is the intercommissural distance, which is 22.6 millimeter. While at the annulus level, but the perimeter derived diameter is 20.6. So my valve sizing will be based on the annulus rather than the supraannulus. The reason behind is here I am getting a smaller diameter and here I am getting the larger diameter. So I don't want to oversize my valve because there might be a risk of rupture during the bicuspid aortic valve. So that's why I will go with the annular sizing. That's how we need to decide how to do it. So this is a screen shot of how to do the three-dimensional analysis. So this is just a summary of everything what we do. So this is how we are going to do is we are just right now is making a central line in all the three phases. This is a cross-sectional phase, longitudinal phase, and the sagittal plane. Then after confirming that we all are in the central line is adjusted in all the three plane, then we will bisect the sinus. So here we are going to bisect the sinuses, and we are putting the on the each of nadir of the each cusp we are putting the 3 dots. So one is red, green, and yellow. Then we will adjust little bit about the annulus across the annulus of these 3 dots, and then it will give us an example where exactly my all the 3 nadir of the 3 cusp. Then we are going to little more adjustment, and then we will join all the 3 cusps, and then it will give us an idea what exactly is my annulus. So now after confirming this, the 3 points of the nadir of all the 3 cusps, we will join all the 3 dots. And once we join all the 3 dots, it will give us an idea what exactly is the. So this is you can see here we can get the minimum dimension, maximum dimension, average, area derived diameter, perimeter derived diameter, area, and the perimeter. So why these all measurements are very important? So minimum diameter is basically decide what will be the minimum diameter of a BAV, what size of balloon balloon aortic valve what we will do. Then this average dimension will decide what will be the post dilatation balloon sizing. This area and the area derived diameter will be useful for the balloon expandable valve for the valve sizing, while the perimeter and perimeter derived diameter is useful to decide the valve sizing in the self expanding valve. So that's why the each and every measurement is very important during the annulus measurement. So then after doing the annulus measurement, we go a little down at the level of 1 millimeter, 2 millimeter, 3 millimeter, and up to 5 millimeter, and see how what's the size of the LVOT. Then we go into the LVOT, then sinus of Valsalva, then STJ, and then ascending aorta. You can see this is how we usually look at the ascending aorta. This is so right now we are scrolling through the ascending aorta, then we are coming down, and then we are now we are at the level of sinus of Valsalva, and then here we can see the origin of the coronary arteries, and then we can see at the sinus of Valsalva all the three cusps, where you can clearly see this is a tricuspid valve. Then here we can see the height of the coronary height, and this is how we are going to assess the annulus. So here we can see this is the yes. So now we are at this is LVOT. So this is we are at the below the 3.7 millimeter below the annulus. So this is how we need to look what exactly is the anatomy and how we are going to deploy the valve during the procedure. So now question comes how to select a valve size. So the valve sizing is different for the balloon expandable valve and different for the self expandable valve. So it's not only the annulus which determines the valve size, especially in the borderline situation where the two valves can be implanted. Suppose a 23 or a 26 millimeter valve, both can be implanted. Then we need to look at the other parameters, that how the LVOT is going to behave, how the sinus of Valsalva is going to behave, how the STJ is going to behave, and then we have to take a decision of exact valve sizing by taking into account of all the 4-5 aspects, and then we need to decide. So just for a simple learning, for the balloon expandable valve, suppose my annulus area is coming somewhere around 300. So 300 is coming between this range 270 to 330. So my valve size will be around 20 millimeter. Suppose my annulus area is coming somewhere around 385. Then my valve will be somewhere around 23 millimeter. But what if my annulus sizing is coming, annulus area is coming around 370? So the 370 is coming between the 21.5 also and the 23 also. So what I will see, I will look at the LVOT, I will look at the sinus of Valsalva, STJ, and then I will decide whether I need to take a 21.5 or whether I need to take a 23 millimeter valve. So this is a different sizing method. Then according to the annulus dimension, we need to decide how much oversizing we are doing during the valve deployment. So in the balloon expandable valve, we usually never oversize beyond 10%. And for the self-expanding valve, we usually oversize between 13 to 31%. So suppose my annulus area is coming around 510. So for 510 annulus area, my 26 millimeter valve will be around 4.1% oversize. I still can take this. But if suppose my annulus area is suppose 510, but for the 510, my 27.5 millimeter will be somewhere around 16.5 millimeter, 16.5%. So I won't take this as a valve size for 27.5. So I would prefer to go with a 26 millimeter valve, which will give you me around 4% oversize. So I never want to go beyond 10% oversizing during the valve deployment. So this is a different sizing method for the Edward. That was and now what about the self-expanding valve? For the self-expanding valve, as I told you that perimeter and the perimeter derived diameter are the determining factors which will govern us what size of the valve should be used. So So it's all depends on the perimeter. So if the perimeter is coming somewhere between the 56.5 to 62, then it will be a 23 millimeter wall. If it's coming between 62 to 72, it will be 26 millimeter wall. If it's 72 to 81, then 29 millimeter. So that's how we decide which wall should be taken into account. But keep in mind, we need to look at the other parameters also. How the sinus of Valsalva, how's the sinus Valsalva height, and how is the STJ and LVOT. Then these are the some certain predetermined factor which we need to be assessed. For example, if we are going with a 23 meter wall, we need at least sinus of Valsalva's diameter at least 25 millimeter. While if we are going with a 34 millimeter wall, then we need at least 31 millimeter of sinus of Valsalva diameter for the wall deployment. Similarly, for the sinus side, if we are going with a 23, 26 or 29 millimeter volute wall, we need at least 15 millimeter height of the sinus of Valsalva. But if we are going with a 34 millimeter wall, we need at least 16 millimeter height for the sinus of Valsalva. Now the next question comes, when to protect the coronaries. So there are certain factors which, so as Dr. Ritu already told, why the coronary obstruction developed. So it's not from the new wall which leads to coronary obstruction. It's because of the native leaflet which leads to the coronary obstruction. Because once we put a new wall inside the native wall, then the native coronary leaflets is going to shift upward. And when we are going shift upward, they might lead to block the native coronary arteries, either left main or right coronary. That's why we need to understand how much is the coronary height from in respect to annulus. And we also need to understand the sinus of Valsalva, and we also need to understand the STJ, sinus of Valsalva height. So that's how we need to assess whether there is a risk of any coronary obstruction or not, and whether we need to protect the coronary during the tower or not. So how we can protect? So if we are in doubt whether to is there any risk of left main occlusion or not, then it's better to protect. How to protect it? We can put a wire inside the left main, we can put a stent inside the left main or an LED, or we can put a balloon also. So if in case suppose there is an obstruction happens after the wall deployment, we can immediately pull back out my stent, and then we can deploy the stent across the left main, and we can protect the patient. Otherwise, this is a rare complication but a dire complication, and it carries a higher mortality. So there are certain anatomical factors and there are certain procedural factors which can govern the risk of coronary obstruction. So what are the anatomical factors? These are the coronary height, sinus of Valsalva dimension, SOV dimension, SOV height, STJ dimension, leaflet thickness and calcium, leaflet length. Then certain procedural factors like type of wall oversizing, final wall implant position. These all factors govern whether there will be a risk of coronary obstruction or not. So whether if we are in diet, it's better to protect rather than regret. So this is a case example of a patient with a we can see the CT annulus dimension, LVOT dimension, and this is a sinus of Valsalva, and this is a coronary height. So we can see there the coronary height is 10 millimeter, left coronary height is 10 millimeter, right coronary height is 16.8 millimeter, and the sinus of Valsalva is 34 millimeter, 35.7 millimeter, and 32. So whenever we have a sinus of Valsalva height size of more than 28 millimeter and the coronary height more than 10 millimeter, we are 95%, we are pretty much sure that there will be no obstruction. But there are certain other factors which we need to assess. What are the other factors? These are the leaflet length and the leaflet thickness and calcium. So look at this calcium. So this calcium is very, very thickened left leaflet calcium, which might put a risk of coronary obstruction. Despite this patient is having a sinus of Valsalva of left sinus of Valsalva is 34 millimeter, and the sinus left main height is 10 millimeter. So we were thinking that there might be a possibility patient will not develop any left main obstruction, but because of this chunk of calcium, we put the wire and we put the stent just to protect that this might lead to a left main obstruction, because it's always better to protect than regret, because if patient develop left main obstruction, patient may die on table. So that's why it's very important, the planning is more important, especially in the left main obstruction. So you can see here, this is the calcium, which is a very thick calcified leaflet in the of the left coronary. Right. So this is the same patient immediately after post deployment. You can see there is a immediate left main obstruction. There's almost no flow in the left main, and then you can see we were already protected it with a wire and a stent, and after this we immediately put the stent across the left main, and then this is the immediate post stent deployment the angiogram of the left main and the patient survive. So overall, the risk of coronary obstruction is rare, but it's a serious. We need to assess the combination of low coronary height and the small sinus dimension. So distance between the aortic annulus and the coronary ostia is more than 10 millimeter, and the sinus of Valsalva more than 20 millimeter. We are pretty much assured. If it's ideally, it has to be more than 12 and 30, but if more than 10 and 28 is pretty much okay. But we also need to understand the leaflet length, STJ size, STJ height, leaflet thickness, and the calcified leaflet. Then what about the implantation angle? So we usually derived an angle. So as I discussed before that the all the three cusps of the right, left, and non-coronary cusp are not aligned at the same level. So we need to understand where exactly all the three cusps comes in a single in a same plane. So we are working basically we are working in a three-dimensional anatomy, but we are looking at the two-dimensional anatomy during the fluoroscopy. So we want an angle where all the three cusp, nadir of all the three cusp comes along a single line, because we want our wall to be deployed below the three cusp, not above this. So, this is derived by the CT scan analysis. So this is very important step for the CT scan analysis for the tower perspective, because we want that angle where we I can put my wall below the all the three cusps. So then certain points about the calcium assessment, we need to understand whether the calcium distribution is symmetrical or asymmetrical. Is there any calcium is extending into the LVOT? What is the calcium distribution across the ascending aorta? Calcification near the coronaries, calcification to the aorta, whether it's a porcelain aorta. We also need to understand there is leaflet calcification, because if there is a leaflet calcification is too much, there might be a risk of PVL. We need to understand is there calcium is extending to the LVOT, because it may risk the risk of PVL, it may risk the root injury, or it may increase the risk of complete AV block. There are certain these type of annular calcium which may risk of annular rupture. So patient may die on table if there is a certain anything happens. So that's why we need to understand how the calcium distribution is across the anatomy. Then I'm not going to cover about this tower and Savar because it's already been covered. So only one point about tower and Savar. Whenever we are putting another tower wall across the prior surgical aortic wall, we need to understand the risk of coronary obstruction. So we need to measure the wall to coronary ostia distance. So if the wall to coronary ostia distance is more than 6 millimeters, the chances of coronary obstruction will be less. But if it's less than 3, then there will be high risk of coronary obstruction, especially into the valve and wall tower. So then few points about the vascular access assessment. So vascular access, what we need to understand during the CT scan analysis, what is the minimal luminal diameter across the iliac, external iliac, and the femoral? Where is there any vessel tortuosity? What is the burden and pattern of calcification, and what is the extent of atherosclerosis? And we need to identify the high risk feature, including dissection and the complex atheroma. So this is a clear, this is a simple, very straightforward anatomy where we can see the bifurcation is well below the both the femur head. There is a straight vessels. There is no significant tortuosity, no significant calcium, and the vessel size is almost 8 into 9 millimeter. We need at least 5.5 to 6 millimeter minimum diameter to negotiate the wall, because what we are going to do is we need at least 14 to 16 French sheath during the wall deployment, which requires at least 5.5 to 6 millimeter of vessel diameter to negotiate the wall. This is another case example where you can see how much is the significant tortuosity across the right and left common iliac and external iliac artery, and there is a significant calcium also. So this may increase the risk of vascular complication during the procedure, and this may also increase the risk of how to negotiate the wall across the aorta. So here we require a more stiff wire to proceed with the procedure. This is another case example where we can see the straightforward vessels, bifurcation well below the femur head, no significant calcium, and adequate luminal diameter. This is another example where we can see there is a acute bend across the at the distal aortic bifurcation, and this is calcified also. So this may increase the risk of difficulty in negotiating the wall. So here we might require a more stiffer wire to to advance the wall. This is the same more tortuosity across the distal aortic bifurcation. Then we need to understand how much is the calcium burden across the vessel, and what is the luminant diameter, and what are the calcium, whether the calcium is anteriorly, posteriorly, or on the lateral aspect, because we don't want to take an access or a puncture where the calcium is there, because it might be difficult to close the it might be difficult to stop the bleeding later on after putting the wall. So what are the hostile anatomical features during the tower? So you can see this is a straightforward anatomical features with an annulus without any significant calcium across the annulus, LVOT, sinus of Valsalva, STJ, and the adequate coronary heights. But what about this? You can see there is a chunk of calcium at the levels of annulus. So whenever there is a chunk of calcium at the levels of annulus, this might lead to risk of annular rupture. There is a calcium at the level of LVOT. It may risk the LVOT rupture. There is a calcium extending to the annulus to LVOT. This might lead to a rupture. It may produce a pericardial effusion tamponade on table. Patient may die on table. So then it will be a very difficult situation. Then the calcium at the level of STJ. This STJ calcium may rupture, and because of this calcium, the balloon may push the wall towards the LV. Then what about the very high calcium score? So this is a patient with a calcium score of more than 2840. So this is a very high calcium score. Because of the very high calcium score, the wall may remain constant after the deployment, and the patient may develop paravalvular leak despite of wall deployment. So, and then other hostile features are vessel toxicity and calcified. So I'm going to show you one case of rescue tower. This was an 86-year-old patient presented with acute decomposite heart failure, cardiac shock, ECG shows right bundle branch block and LAHV. Echo shows severe aortic stenosis with valve area of 0.4. Patient was kept on ventilator support, diuretics, and high dose vasopressor, noradrenaline, dobutamine, everything. But patient was unable to be in the inotropic support for last 6 days. And the EF was only 15% and creatinine was 1.7. So this patient was not going to survive without valve surgery. So as the surgery was very high risk, so we will proceed to go for the tower. So we counseled the patient, considered the procedure, and tower CT was done and analyzed. So we can see there was some annular calcium, some LVOT calcium. There's a calcium extending into the towards the leaflet, and this is the leaflet. Sinus of Valsalva were adequate. Coronary heights were borderline on the left side, and this was the femoral views. And then, so what were the challenges? So challenges was advanced age, critical AS, CHF, severe LV dysfunction, risk of cardiac arrest during rapid pacing, cardiac shock, baseline creatinine 1.7, bifascicular block, severe annular calcification because it might risk of annular rupture, severe LVOT calcification which might risk of LVOT rupture, dilated LVOT, risk of wall migration, and the tortuous calcified iliac arteries which might lead to risk of vascular complications. So we did the coronary angiogram, which shows the non-obstructive coronary arteries. We did took the coplanar view, which shows so this is the coplanar view where we can see all the three cusps can be seen in a. So we can see the left, right, and the non-coronary cusps all are coming in a similar across the single line. Then we did a balloon aortic valvotomy with 18mm balloon without any pacing because the EF was low. So we don't want it to keep the patient on a rapid pacing. Then we deploy a 24mm wall with a 5% oversizing, and this was the wall deployment at the under rapid pacing. And then this is the final aortogram. So we can see there's a wall deployment across the aortic annulus, and there's no paravalvular leak, and both the coronaries are flowing. There is no dissection, and with a good wall position. So post-procedure, patient developed almost zero gradient. No, on echo there was no PVL, no aortic regurgitation. Blood pressure rose to 130/70 on table. There was no conduction system disturbance. And in next 4 hours, patient becomes off vasopressor. In 24 hours, patient extubated. EF improved to 40%. And on day 3, patient shifted to room. And on day 4, patient discharged to home. I would like to conclude at this point. And if we have any question, we can discuss.
Thank you, Dr. Prashant. That was really an excellent talk. Both the talks were really complementing each other with clinicians' view and the radiologist view, and this was really a great meeting. Are there any questions? Any of the faculty members, EC members would like to ask anything?
Uh, yeah, can I ask her?
Yeah, sure, please.
Is there any importance of distance
yeah.
to related to sternum, position of aorta related to sternum, and do you need it at multiple levels? I mean, at the manubrial level also, and at the, or is there any specific information that you need?
So, so distance of aorta from the sternum, rather than the sternum, I would like to know more about the graft position, because the question is, if the patient is having a prior CABG and the patient has a coronary artery bypass graft, which is coming directly anteriorly from the aorta, and it is going to supply the OM or the LAD, or the if the SVG graft is connected to the OM or a PDA, I would like to know the where exactly is the graft position. So rather than the sternum, I would like to know the what is the graft position. It's not going to change much during the intervention point of view.
Thank you.
One other question.
Yeah.
Post-op TAVR cases. So when do you advise CT compared to transesophageal echo? I mean, where TE would have limitations and CT only would be the choice.
So the post-tower patient, when the patient is having so both the technology are complementary to each other. But one is whenever the patient of a post-tower developed any new onset dyspnea or something, we find out in the 2D echo that there is an obstruction or there is a leakage or there is an aortic regurgitation or now the new aortic stenosis or now there is any new increase in the gradient. So what we need to do is we need to assess whether there is any leakage or not. So for the paravalvular leak perspective, we need to understand whether there is an PVL or not. That for that we need to do a transesophageal echo. But if there is no paravalvular leak or if there is no aortic regurgitation, but still there is some increase in the gradient, there we need a CT scan analysis more than the transesophageal echo, because we want to understand is there is any halt, hypoattenuated leaflet thickening, or is there any thrombus, or if there is any vegetation across the aortic wall, where the CT gives us a more idea rather than the transesophageal echo. So these are the certain factors which we require the CT over the T. If we need to understand the paravalvular leak or aortic regurgitation, and then we need to do a T more. If we need to understand the aortic wall thickening or a thrombus or any vegetation, or if there is any under expansion of the wall, or if there is any calcium which is impinging the wall expansion, then we need to do a CT scan analysis.
What is the reason of halt? Why does it occur?
So halt is basically it's a subclinical phase, because the patient of these patients are usually old age patient having a severely calcified wall. So sometimes even after deployment of the wall, that time the patient develop no gradient, but because of the calcium, the patient may have some form of restriction in the leaflet. So these restriction in the leaflet, and because of the valve hemodynamics, patient may develop thickening of the leaflet, and because of the leaflet thickening, there might be a development of some thrombus formation over this. So because of the valve hemodynamics, patient develop this halt, and once the halt develop, there might be high risk that patient might develop a thrombus. But most of the time these halts disappear by giving just the oral anticoagulation for 3 to 6 months.
There is a question about femoral vein approach.
Yeah.
Yeah.
So so most of the cases, 95 to 98% of the cases are being done from the transfemoral artery. There are certain other other access also when the transfemoral are not suitable. Suppose there is a significant calcium in the across the femoral artery where we can't take the access, or bilateral common iliac is already CTO 100% occluded, then we can't take the access. Then we have to look for the other axis. Then what are the other axes? We can take the axis from the subclavian or the axillary. We can take the axis from the direct aortic. Then we can take the axis from the apical, and then we can take also axis from the femoral vein. So how to we can take the axis from the femoral vein is, we go through the femoral vein, we go into the IVC, then infrarenal, below the infrarenal artery and vein, we puncture the IVC and we enter into the aorta. From IVC to aorta, and then we go up into the aortic wall. We do the procedure. After completion of the procedure, we close that hole with a device like a PDA device, and then we come out. This is how we do the IVCs. This is basically known as a cable approach of doing the TAVR.
Ritu, probably you can answer this about aortic annular axis. I think it means the aortic root angle. I mean,
Yeah, I can go back and share my slide and answer this question, I guess. So I hope my PPT is visible again.
I
No.
will stop sharing. I will stop sharing now.
Okay.
Yes, now we can see.
Just can you see now?
Yes.
Yeah, so to see the annulus, as I said, that is the first image that you get. So you have to align this blue line along the long axis of the aorta, and then this yellow line, you have to turn it a bit, curve it around so that it comes again to the long axis of the aorta. When you do that, you have this the tricuspid aortic valve, and if you scroll inferiorly from this valve, you get this annulus. I hope that answers the question. So this is the aortic annulus, how we measures that.
I
And
think
I think
they are trying to know how you measure the deployment angle on CT for aortic axis.
Okay.
Horizontal aortic angle, yeah.
Yeah, so the deployment angle, I guess I am not giving those on CT, but the deployment angle is the angle between the LVOT and the angle between the LA and LV and the LVOT. I guess I do not usually measure that. That's probably done better in the fluoroscopy. That's what I think. And Dr.
So-
Prashant can tell me better.
I will answer that question. Yes. So aortic root angle is basically an angle between the aorta and the LV. So if the aortic root angle is more than 60 degree, it's considered as a horizontal aorta. So whenever it's a horizontal aorta, it will be slightly difficult to negotiate the wall and slightly difficult to position the wall. So here we need a relatively more stiff wire to position the wall and everything. So how to get this horizontal aorta angle? We usually measure it in the 3-man show. I might need to share the screen again for this. I can show it.
Yeah, I can shop sorry.
So
So Dr. Prashant, most of
Yes.
us do not have dementia. I mean, we are doing
Yes.
it on our
yes,
scanners. We do the processing, and I'm sure all the interventional cardiologists, they do it on a dementia. I mean, what is your experience? What is the percentage variability? Because most of us do not have a dedicated aortic valve measurement software.
yes. So most of the time, the annulus measurement are almost similar when the radiologists do or the cardiologists do. Only question comes when we are having especially in a borderline situation where we need to understand whether we can go with a 23-meter wall or a 26-meter wall. In those perspectives, we need this dedicated software more because we need a more accurate dimension measurement. Otherwise, most of the time, almost 80 to 90% time, most of the findings are usually correlated to each other. And there are certain other factors which we need to understand, which radiologists can't give with their normal software. So here we need to three-dimensional analysis, especially for this aortic root angle and certain other factors like proper exact annular position, where we need to understand, and the membrane septal length, and these things sometimes we need to understand. So from that question point of view,
I think CT can answer most of the questions except for the fluoroscopic angles. I think horizontal deployment angle can be very well assessed with CT in a coronal plane. I think it fails to answer only one question, that is your radiographic angles, the fluoroscopic angles.
Yes.
Other than that, I think everything else can be done on a normal routine CT with MPR capability and curved reformat imaging.
yes, perfectly same. Yeah. CT can answer almost all the questions. So if in an emergency we don't have any three-dimensional analysis, we can still do the tower without any three-dimensional analysis. And sometimes when the patient is having a contrast allergy or a patient is having a high creatinine, we do a non-contrast CT, and then we do a 3D also to assess the valve sizing, and then we do wall deployment without any contrast. I have done few cases without any giving any contrast and doing the tower. So unfortunately, I don't have that slide how to make the angle.
No problem, no problem. We can share with them later on. So thank you, Dr. Ritu and Dr. Prashant, for your valuable time. It was really a great learning experience. Next month, the academic meeting, probably Dr. Zishan will be taking on the other valves. So apart from aortic, the mitral, tricuspid, pulmonary valve assessment, and she will be taking it ahead. So feel free to ask your questions. If you have any suggestions for your topics also, please share with us. Once again, I thank Dr. Prashant and Dr. Ritu. Thank you very much. Good night,
Thank you.
everyone.
Thank you, Dr. Priya. Thank you. Thank you,
Thank
Dr.
you.
Ritu. Thank you, everyone.